Hello, my name is Brian Custer, and I am an epidemiologist and work at Vitalant Research Institute in San Francisco, California. So, an affiliate faculty member at the University of California in San Francisco. I want to thank the Donor Research Network organizers for the opportunity to present to you today about the ADVANCE study and the work that we are doing related to blood donor deferral for men who have sex with men. So again, thank you for the opportunity to present today. I'm going to talk to you about the ADVANCE study. The ADVANCE study stands for Assessing Donor Variability and New Concepts in Eligibility. Before I do that, I do want to give you some background context for how we think about this particular issue in the US context and also some of the broader considerations. So blood donation by gay and bisexual men, or the way that I'll refer to it in this presentation is men who have sex with men, has a number of different aspects to it. The question of allowing sexually active gay and bisexual men to donate is about addressing exclusion rather than inclusion, because in many settings right now, they are excluded from donating or potentially excluded from donating. So if the promotion of equity is considered important in a blood service or specific jurisdiction, this requires consideration of who should be allowed to be a donor and what is the evidence base that supports that. We all are aware that many changes to allow some men who have sex with men have actually occurred in the last several years throughout the world, particularly in the countries of the United Kingdom, the Netherlands, France, and others. There have been significant changes in policies to allow more men who have sex with men to be potential donors. However, these changes still leave unanswered questions and policy considerations. So that movement toward equity is clearly happening, but how it is happening and how it is implemented also has to bear in mind some contemporary considerations. So as background, there are different ways of thinking about deferral for men who have sex with men or other categories of individuals that may have higher risk. One are time-based deferrals. So these could be indefinite deferrals, 5-year deferrals, 1-year deferrals, or 3 to 4 month deferrals, whatever the time period. But it's saying that if you had the specific activity in that time period, you are deferred from donating until that period has lapsed. Another approach is use-based activities or gender-neutral policies, where if you have a specific sexual behavior, regardless of your sexual orientation or gender, in a specified time period, you would not be allowed to donate. This is another form, I think, of individual risk assessment, or at least is on the pathway toward a specific approach that allows individuals to be considered regardless of their contextual considerations, just on their behaviors alone. And then there are refined policies that sort of try to steer between the two. So allowing individuals, such as men who have sex with men, to donate if they are giving a certain kind of donation, such as plasma for quarantine, or potentially donating with the use of technologies such as pathogen inactivation. And then the news, very recent news, very important to consider, is Canadian Blood Services to remove the eligibility criteria specific to MSM. I'm covering this just to say that, again, the jurisdictions continue to change and evolve the policy really at real time. So just in the end of April, Health Canada approved the request rather to allow eligibility criteria to drop the MSM as a specific criteria for selecting donors. And it will be implemented later this year. And this change will lead to any man who has sex with another man no longer being specifically asked that question. And instead, all donors will be asked a series or a hierarchy of questions. All donors, regardless of gender or sexual orientation, will be asked if they've had new or multiple sexual partners in the last 3 months. If they answer yes to either of those questions, they'll be asked if they've had anal sex with any of these partners in that same period. If they have, they will not be allowed to donate, rather. Instead, they will be deferred for 3 months. However, if they've not had anal sex and they meet all other eligibility criteria, they will be allowed to donate. And I think it's important to point out that it's if they meet all other donation eligibility criteria, they'll be allowed to donate. It's really some of those other criteria that I think are where we are moving with respect to thinking about men who have sex with men and donation in contemporary HIV prevention strategies consideration. So the contextual considerations are there really, I think, still is a high level of controversy surrounding what defines evidence-based science policy. Current testing approaches do not justify an indefinite deferral, or even for that matter, an extensive time-based deferral. Our technologies are just simply too good. We can identify HIV infection relatively soon after it may have been acquired. I do think it is true that the primary concern is still HIV and other known infections. I'm saying that just because the consideration around emerging infectious diseases could be a potential reason for not changing a policy, but our observation of what has been the emerging agents in the last 20 years really doesn't support the fact that this would be a justification for not further changes to the policy related to men who have sex with men. So analyses of changes in deferral periods for men who have sex with men show that the gains to the supply, so the number of new individuals who are MSM who would be allowed to donate, is really insufficient to say that's the only reason why you would make this change. However, if you really are more interested in issues related to equity, so allowing everybody to be treated as equally as possible, and also the broader consequences of the negative impact on this policy for other participants or other people who may be donors, that's where I think that the considerations around policy change really are actively engaged right now, and we're trying to do the work related to understanding that impact. We are aware that HIV control and prevention strategies have been phenomenally successful in really changing the course of the HIV epidemic. And here are two examples of masthead titles from publications, really from Australia Lifeblood, thinking about these issues, what we do in the face of pre-exposure prophylaxis or the use of antiretroviral therapy, and how do those contribute to our allowing men who have sex with men to donate or not. And the reason why it's such a complex topic is because there's a conflicting message between public health with HIV prevention strategies and blood donation. So in the United States, it's very common to see U equals U, or undetectable equals untransmittable. So if somebody even was HIV infected, that if we cannot detect it, if we cannot detect it, they may not be able to transmit it to a sexual partner. And while this may be true for sexual exposures, this is not thought to be true for blood donation. Of course, that's because of the size, the amount of plasma that's in a donation, and the fact that it's being administered intravenously. So all of those give us quite a bit of concern about what do HIV control and prevention strategies mean in the broader context of changing the policy for men who have sex with men. I'm only going to focus on the right side of this, and just to say that in looking at that and thinking about pre-exposure prophylaxis use in blood donors in the United States context, this study is a couple of years old, but when we conducted this study, we specifically looked at a sample of donors who were first-time male donors in metropolitan areas, and did find small but evidence of pre-exposure prophylaxis use among accepted donors. So 0.6% of about 1,500 individuals who we sampled did have evidence of pre-exposure prophylaxis use. In a separate way of looking at this topic, we actually conducted an interview with the National HIV Behavior Surveillance Survey and saw that there was a substantial proportion, almost 5% of men who have sex with men, saying that they had contemporaneously, so not directly specifically linked in time, but at approximately the same time, had used pre-exposure prophylaxis and also been a blood donor. All of this, I think, helps us to understand that we need to have a deeper understanding of pre-exposure prophylaxis use in this patient or in this donor population. So I'm going to just spend a very few couple of minutes walking through the policy for men who have sex with men in the US, only because, while it's fairly similar to what it's been in other developed countries, it'll give you context for the specific study that we're doing, the advanced study. So in that period from 1983 to 1985, we really did not know the agent was HIV specifically. And so a whole group of individuals, different groups of individuals, were deferred from donating because they were perceived to be at higher risk for HIV infection. During that 30-year period from 1985 to 2015, any man who ever reported having sex even once with another man since 1977 was indefinitely deferred from donating. 2015, that changed to a 12-month deferral since last sexual contact. So clearly a time-based deferral, but now 12 months, a step in the right direction, but essentially an indefinite deferral for anybody who is sexually active. And then beginning in 2020, this changed to a 3-month deferral since the last sexual contact. So that's the current policy in the US, is this 3-month deferral since last sexual contact. At the time, the US FDA changed a number of different deferrals from 12-month periods to 3-month periods. One thing that maintained, it was a 3-month deferral at the time and is still a 3-month deferral, is any individual who reports taking pre-exposure prophylaxis or post-exposure prophylaxis is deferred and will be deferred for at least a 3-month period following the discontinuation of use of pre-exposure prophylaxis. However, in addition to the 3-month change for men who have sex with men, there were many other deferrals that were changed, again, from 12 months to 3 months, as you can see, exchanging money or drugs for sex, non-injection drug use, a person who has ever had sex with somebody who was known to be HIV positive, a new body piercing, tattoo, or ear piercing, a woman reporting that she had sex with another man, an individual who recently tested positive for another sexually transmitted infection, and any individual who reported in the past 3 months receiving any form of transfusion themselves. So it's a large context of change deferrals. And against that background, we're now doing further work related to whether we can further change the policy with respect to men who have sex with men. So that leads us really to the rest of the talk is about the advanced study itself, what we are doing. So this is a project that was funded by the US FDA. It's important to recognize, I think the FDA realized that new data, better evidence needed to be available, and that's why they've actually supported this study. It was designed through a collaborative process called the Blood Equality Working Group to assess potential alternative blood donor deferral and selection strategies for men who have sex with men. It was conceived as a pilot study that may help determine the feasibility and size of a larger study to assess whether further elimination or reduction of the time-based deferral for men who have sex with men is possible. The enrollment target is 2,000 eligible participants in all of the participating locations. And the thinking was that a larger study, this would help define a larger study by helping us to understand what would be the potential set of behavioral questions or responses that are associated with the absence of the detection of HIV, and then a larger study would be designed to really assess that particular question. So the advanced study, really its primary objective is to conduct an initial assessment of the discriminant function of revised donor history questions for predicting recent infection with HIV in men who have sex with men who wish to be blood donors. So obviously not all men who have sex with men wish to be blood donors. So it's the group within the larger population of MSM who may be interested in blood donation. There are secondary objectives to evaluate the recency of infection in those individuals who do test HIV positive by individual nucleic acid testing and antibody-based testing, and to identify risk factors among those individuals with recently acquired HIV infection. But we all recognize that the likelihood of detecting somebody who has a recently acquired HIV infection, whether it's NAT only or NAT plus antibody positive and determined to be recently acquired by ligavidity testing, really is probably fairly small. And for that reason, we are also focused on pre-exposure prophylaxis use in this population. And as part of this study, we are assessing the use of PrEP in the study population to provide currently unknown contextual data. Then we also have an eligibility screening questionnaire, which gives us some larger information about individuals and why they may be ineligible to donate if this was the only policy that was changed in the future. So the study design is really, it's a two-part study, meaning there are 2 study visits. And the first is an enrollment visit. The enrollment visit includes all presenters, so anybody who comes in to potentially be in the study, and they complete an eligibility questionnaire. This covers sociodemographic characteristics and other deferrable risk behaviors that would exclude somebody from donating, as I indicated earlier. For those who are eligible and consent, they complete the HIV risk questionnaire, or what we call the HRQ. These are the test questions that might one day be on the US version of the donor history questionnaire that would screen out potential risks for HIV among MSM. In addition, a blood sample is collected for HIV and also tenofovir testing, one of the drugs in most forms of pre-exposure prophylaxis. The blood sample is tested by the individual sample format for NAT and also fourth generation serology using blood screening assays. We're doing confirmation testing also using blood screening assays if relevant, and we're using a research use only limiting antigen avidity test with NAT if those individuals are NAT and serology positive. So if they've already seroconverted, this is how we indicate that they've had a recently acquired HIV infection. In addition to that is the PrEP testing. So research use only tenofovir colorimetric enzyme-linked immunosorbent assay. We are using a whole blood sample format, and there's some specific reasons why we're using whole blood. It's really to be able to detect PrEP use further back in time than just what might be bioavailable in a plasma-only sample. After about 14 to 21 days, so when all of the testing is completed, we do ask everybody who participates to come back for a notification visit of what the HIV testing and PrEP testing results are. In addition, we ask them to complete a much more detailed behavioral inventory of epidemiologic characteristics associated with their particular test results. At the beginning of this study, up until September of 2021, this was only eligible for individuals who tested HIV positive or for which we detected or they reported PrEP use. We changed that study design now so that every individual who comes back for a notification, whether they are HIV negative or positive, whether they're using PrEP or not, are now eligible for the follow-up interview. So we are now getting questionnaire data, this detailed behavioral data on all participants. Study sites for this is an interesting, first of all, collaboration among blood centers in the United States. So 3 large blood centers, the American Red Cross, OneBlood, and Vitalant are all collaborating together on this project. Red Cross is leading the study in Atlanta, Los Angeles, and Washington, D.C. OneBlood is leading the study in Miami and Orlando, and Vitalant is leading the study in Baton Rouge, New Orleans, Memphis, and also San Francisco. The requirements for being in the study are to be between the ages of 18 to 39, to be male at birth, to have had at least one male sex partner during the past 3 months before enrolling in the study, stating a willingness to donate at some point in the future, and the individuals must reside in the geographic areas where the study is being conducted. There are some other criteria that the participants also have to meet, and I'm going to show you those on the next slide. We ask everybody to actually engage with us initially through scheduling an appointment at the Advanced Study website. You can see the URL there. So here are the eligibility, inclusion, and exclusion criteria. I really just covered the inclusion criteria already, but there are exclusion criteria. As you can see, reporting recent injection drug use, exchanging money or drugs for sex, a recent STI diagnosis, or any history of being HIV positive are exclusion criteria. These, of course, are exclusion criteria because the expectation is that these will continue to be exclusion criteria in the United States should the MSN policy change to an individual risk-based or different question approach. Here's an example of what the actual website looks like, or at least one part of the website. The website is intended to do a number of different things. First, give people information about the study, give a little bit more background on the history of the policy itself, and also be a tool that allows individuals, again, to schedule a study visit. So that's why we have the 8 different blood drops shown here, and the opportunity to then go deeper and actually schedule an appointment for an eligibility study visit at any of the participating research study locations. For most of the locations, even though we have the study being conducted in 8 large geographic or city areas, there's actually multiple enrollment sites within each city. Typically 2, sometimes 3 different locations are available for people to participate in the project. Here's just a snapshot of some actual in-process of what we're seeing in terms of how people are telling us they're learning about the study. So we are about halfway through enrolling participants. So we've gone over 1,000 enrolled participants, still working toward getting to 2,000 participants. But we do ask everybody, how did they learn about the study? And as you can see, there's some sort of clues in this graph about how performance is going, with the Washington, D.C. site clearly having the largest enrollment so far, with Orlando, San Francisco, and in particular LA having very strong enrollment. And some of the other sites, we're still really figuring out how to effectively turn on enrollment. And then in addition to that layer, now how people tell us they're learning about the study. And you can see by far, most people are telling us it's by a social media site, some sort of interaction with social media. Or with the red bars, you can see conversation with a friend or acquaintance. So some sort of one-on-one conversation that spurred somebody to be interested to sign up for an appointment and to come in and to participate. The age distribution is also, of course, something that we're very interested in tracking. And so while we have the ages of 18 to 39 as eligible, we do break that into 4 different categories just to see how we're doing. Really trying to get as much representation across these age groups as possible. And as you can see, again, by site, how we're doing relative. And so some sites have generally a little bit better participation in younger age groups. Some of it's a little more even. But again, at this point, just an example of kind of insights into what does our study population look like so far in the project. To be able to do this study, there are many other organizations and efforts on outreach. And it's really the rest of this talk is going to talk about how do we effectively do donor-related or donor potentially related research by reaching out to communities that aren't specifically blood donors. We've had to do that in a number of different ways. Of course, through the COVID-19 pandemic, it's been extremely challenging, but we've had opportunities, and increasingly so, to do community outreach. And events like the Custer Street Fair, this takes place in San Francisco every October, is an opportunity for us to directly reach out to the community and enroll participants also right on the spot. Very traditional form of outreach at various things such as Pride events. So here you can see, if you happen to know San Francisco, we're right here at the corner of Market and Custer Street, where all of the streets are obviously cordoned off, doing our promotion for the study last fall. Similarly, we do other kinds of outreach. Again, there was recently, just here in April, Miami Beach Pride in South Florida. So another thing that's important to see here, of course, is you can see we have banners that tell people about the study, both in English and in Spanish. So this study is being conducted in English and in Spanish, and the website itself is both in English and in Spanish, so that we are trying to get as much diversity among the MSM population represented in our study as possible. Just more pictures of what booths look like. You can see it looks really similar to what we saw for the Custer Street Fair, but it's trying to be colorful and engaging and ask people to think about considering participating in this study. This kind of actual community outreach, I think, is critical to the success of the study and been one of the biggest challenges, as I mentioned, during the COVID pandemic. The other form of outreach is really through digital advertising. So we have quite a bit of digital advertising that is being done on Facebook and Instagram. And we also do print these materials. So these are examples, actual proofs of printed materials. So palm cards or hand cards that we can leave in bars and restaurants or community centers to raise awareness around the study, as well as posters. We've also tried very much intentionally to reflect diversity and inclusion in those we're trying to reach out to try to, again, make this study as diverse and as representative of the MSM population in the US as we can. So we have what we hope are catchy messages like "What can your blood do?" Groundbreaking study describing who might be eligible for this study. That this is enough. We do certainly use current features like QR codes and materials like that to be able to help facilitate the ease of access to scheduling an appointment. So this has really been used extensively and continues to be a very effective way of raising awareness. So just very briefly, the study is actually taking a little bit longer than expected. We will now be conducting study enrollment through September of 2022. So that is about 8 months longer than originally planned, but frankly necessary to try to get us to the overall enrollment target. In addition, we will be conducting analysis through the end of 2022. So the study is being conducted, funded, of course, by the FDA, as I said at the beginning, but also as a collaboration with the FDA. So there's an analysis working group that works jointly to both conduct the statistical analyses that will be done for the study, as well as the interpretation of the findings. All of that information will be handed over to the FDA, who will then think about, is this sufficient information to either conduct additional research or potentially move to a different policy formulation with respect to men who have sex with men in the US from the current 3-month deferral. I cannot say what's going to happen, but I do think we are conducting unique data with the scope and the breadth related to HIV prevention strategies and other behaviors that may or may not predispose somebody to have a higher risk of HIV infection, will give us an opportunity to really inform the policy, to hopefully see the policy change. That's certainly my bias, but nonetheless, we'll see what the results bring. I do want to comment, as I said, this is about partnering with community organizations, and it really is a substantially large effort. In addition to those blood centers, you can see them listed, One Blood, Red Cross, and also Vitalant. All of the different LGBTQ plus community centers or health service organizations in each of the different 8 geographic locations where the study has been conducted is critical to the success of the study. And so just even building partnerships between blood centers in the US and these organizations is a really large step forward and has been very important in terms of being able to help people understand the policy, what we think it will take for policy to change, but also have established a real meaningful dialogue about the implications for change and how to actually participate in the process of change. So I'm showing you all of these icons or logos of these different organizations just to give you, again, a sense of the amount of collaboration it takes to achieve a study like this. This just gives a list of names, and I'm not going to read the names, but I just wanted to say, in addition to the organizations, of course, there's specific individuals in all of the different blood collection agencies, as well as these LGBTQ plus community centers and other organizations who really are making the study happen. And I just want to acknowledge some of them. This is not an exhaustive list. Finally, I want to thank you, the DoRN network, for the opportunity to present today to talk about the advanced study in the US, and also encourage you, if you have questions or comments around the study or want to pursue a little bit further discussion about the thinking of this policy in the US context, I would be more than happy to speak to you. So please do feel free to reach out to me. My email address is bcuster@vitalant.org. And in conclusion, again, I'd like to thank the organizers, the Donor Research Network and the University of Queensland, for the opportunity to present to you today. Thank you.